Welcome, ladies and gentlemen, colleagues and friends. My name is John Martin, and I'm the Chief Medical Officer of Butterfly Network. And I'm glad you could join us for what I believe will prove to be a most informative and maybe even a provocative hour of discussion regarding lung ultrasound, and in particular, lung ultrasound and COVID. You know, it'd be nice to believe that with the arrival of the vaccine, that the worst is behind us. But sadly, I think that's far from the truth. One would also like to believe that after battling this pandemic for the better part of 9 months, that the important lessons learned and the best practices identified are ubiquitously shared across the globe. But as is always the case in medicine, adoption is notoriously slow, and we're constantly learning. Challenging the status quo is a Herculean task, particularly in times of stress. But these special times demand that. We do so not because it's the PPEs or the ventilators or remarkably even beds that are the limitation. It's the human capital. They're stretched to capacity and a resource that we just cannot manufacture. We must adopt practices that improve efficiency, limit exposure, and admit only those patients that actually need hospitalization. That is what tonight is all about. These priorities don't only apply during this pandemic, they're also critical to cost-effective care in the future. We are so fortunate to have an incredibly experienced panel gathered for this webinar that will offer you their insights, suggestions, and answer the question of the evening. Should lung ultrasound be the standard of care for preliminary assessment of lung pathology? Good question. So the current battlefront demands of our clinicians, and they also required us to make tonight a little combination of live interviews and tape conversation with some of their experts. We wanted to make sure that their clinical responsibilities that pulled them away this evening did not get in the way of us sharing their invaluable insights. Our panelists include Dr. Jennifer Pena. She is a hospitalist at Inova and the medical director of Global Executive Medicine. Dr. Daniel Duran, he's the chairman of radiology at LifeBridge Health in Maryland. Dr. Emmanuel Pavetta from the Division of Emergency Medicine at the Molinetta Hospital in Torino, Italy. Dr. Joseph Noonan, an ultrasound fellow at the Royal Berkshire Hospital in Reading, England. And Dr. Ryan Gibbons, the director of ultrasound and medicine at Temple in Philadelphia. And also from Philadelphia, Nareen Ahmed. She's the assistant professor of clinical medicine, the Division of Pulmonary and Critical Care at the University of Pennsylvania. And finally, my good partner, Mike Stone, an emergency medicine physician extraordinaire and the vice president of education and ultrasound at Butterfly. Welcome, everyone. And Mike, let me pass the baton to you to start our evening.
Thanks, John. Really excited to share with everyone the expertise and the insights from this amazing panel of speakers and experts. I'm going to go ahead and start us off with a recorded interview. Last week, I had the pleasure of sitting down with Dr. Jennifer Pena and getting her impressions about the state of COVID-19 at the moment and where we are in the pandemic, and particularly around the potential role for lung ultrasound as well. Dr. Pena, thank you so much for joining us.
Thank you so much, Mike.
We're going to start off and ask you to frame this conversation a bit by telling us where we stand in the COVID-19 pandemic at this time. It's no secret that the world is dealing with this. Obviously, you know, we don't need to go back to the beginning, but sort of where are we now as compared to where we were, say, in the spring or the summer, and why is it important for us to keep talking about this?
Yeah, so it's an excellent question. I mean, obviously, right now we are at the worst of the pandemic. You know, even worse so than at the very beginning. Unfortunately, pandemic fatigue, if you will, has set in. People are tired of being at home, of quarantining, of maintaining social distancing, especially as we're in the midst of holiday season, and you know, folks are longing to be with their loved ones. And so unfortunately, we're seeing the highest rates of daily deaths. If I get this number correctly, I believe overnight here in the United States, it was 2,600 reported deaths in the last 24 hours. The daily case rate and positivity rate pretty much ubiquitously across the United States is tremendously high, double digits. And so, you know, the hard part about this is that as we get a light at the end of the tunnel, if you will, regarding vaccine development and the potential for vaccines to be deployed here, hopefully in the next couple of weeks, we have to remind people that we can't let our guard down. We're almost there. We're almost at that quote unquote finish line where we can finally get something that will really help prevent the continuous spread. But we can't let our guard down. We have to continue doing the things that we know are proven to be true and to work, wearing our masks, social distancing, appropriate hygiene. And, we hope that, again, with the deployment of vaccinations, things will start to settle down here, but that's not going to happen overnight. That's still going to take probably a couple of into that first quarter of 2021.
Lung ultrasound has been around for a really long time in terms of proven utility in emergency, pre-hospital, military, critical care settings for a variety of conditions. Pneumothorax, most commonly for the military setting or pre-hospital setting, but also pneumonia, pleural effusion, congestive heart failure, pneumonia, ARDS. The literature to support the accuracy of lung ultrasound and generally superiority to chest X-ray, comparability to CT, but with the advantages of portability and repeatability and convenience at the bedside without patient transport. What's stopping us from having this be best practice and standard of care right now? Where do you think the barriers are to taking the knowledge that already exists and has only been emphasized in the last year and making this a standard practice for providers who assess patients with respiratory disease?
Yeah, I'm going to use myself as an example. I think it's a lack of education. At least from an internal medicine perspective, just recently we're starting to make point of care ultrasound part of our residency training programs, as well as education seminars in our professional meetings, et cetera. But I'll tell you, I mean, when I went through residency over a decade ago, this was not something that was built into our residency programs. We weren't taught how to use point of care ultrasound. That was left up to the emergency medicine physicians and folks who needed to use it, for other things, say in the ICU and for cardiology. I had a unique experience in the military and in which I was taught to use point of care ultrasound, but as you mentioned, it was really used for trauma. To do fast exams, to check for pneumothoraces and things of that nature. So back in the hospital, I felt very apprehensive because I had never really made it a part of my practice. As I matured into my career and had the opportunity to manage hospitalist teams and man ICUs in smaller military community hospitals, finally we started making point of care ultrasound mainstay for line insertions. And so then we started educating our residents to do that. But again, COVID has really fast forwarded the need for education in point of care ultrasound for a lot of specialties outside of the emergency room. And so I personally have taken it upon myself to teach myself how to use it really out there in the hospital, on the field, on patients. As you mentioned, POCUS has a great sensitivity for the pulmonary manifestations of COVID, and we're able to use it, minimize nosocomial spread of disease. Obviously, as you mentioned, chest x-rays, CT scanners are scarce. They require special cleaning after they're being used for COVID patients. And so point of care, again, is very easy to protect and very easy to clean. And it's great to prognosticate and assess that response to therapy as well. So once the patient is in the ward and we're going through the process of monitoring these patients' response to different treatments, it's a great tool to have to use on your daily rounds on these patients. And so I think, again, that barrier really comes down to education. I think that this pandemic has highlighted the need to make this a mainstay of residency education for a myriad of specialties. And I think that going forward, that's really what's going to bridge that gap, make providers feel more comfortable. And I should mention, even in the outpatient setting. So I've actually started to use it to follow up with COVID patients to again, continue to assess their progression, especially for these long haulers who continue to have pulmonary manifestations instead of having to inconvenience them and send them in for imaging when they're already not feeling very well. This is something that we can easily do in the clinic. And also, pre-hospitalization for patients that come in with positive COVID tests, we're able to assess, if they have consolidation, if this is something that maybe is related to a different condition, heart failure, COPD, and really make those distinctions before we expose them and others in the hospital, burden the emergency rooms, overwhelm the hospitals even more. So I do want to say that outside of the inpatient setting, this tool has great use in the outpatient setting as well. And so again, education, really making this a mainstay of residency education. I think that that's what's going to make a huge difference going forward.
Well, thank you, Dr. Pena. It's always a pleasure talking to you. I really appreciate all of your insight and thoughts on what we're dealing with, and happy to have you back anytime.
Likewise, thank you so much for having me.
Fantastic. So, you can't really talk about lung ultrasound without including the Italian experience. Italy has really been a mecca for lung sonography for decades at this point. And next up, I had the privilege and pleasure of speaking with an old friend and a colleague, Emanuele Pavetta, in Turin, about his recent publication on the use of lung ultrasound in the assessment of patients under investigation for COVID-19, and also just their general clinical experience thus far with lung ultrasound. And I think you'll enjoy hearing from Emanuele. So we're really excited to have with us Dr. Emanuele Pavetta, who is a former colleague and friend, as well as a world expert in lung ultrasound and ultrasound research. He works in the Division of Emergency Medicine and the High Dependency Unit in the Department of General and Specialized Medicine. And Emanuele, I'm going to ask you to say the name of your hospital, because I will butcher it if I make an attempt.
Okay, so the name of the hospital is Città della Salute e della Scienza di Torino, the Molinette Hospital in Turin, Italy.
Fantastic. Thank you so much for making time to speak with us.
Thank you for inviting me.
Of course, of course. So I know, and the world knows, that Italy was hit very hard with the COVID-19 pandemic in the spring. And I know that we were in touch frequently during that phase, and you were working tremendously long hours, as was everyone in the healthcare system. And there was really sort of the Western world's first glimpse into what was coming came out of the Italian experience. And obviously, it sounds like things are still troublesome with COVID-19 in Italy, although much improved from the spring. I wanted to get your perspectives, particularly on some of the research that you've been doing. There are lung ultrasound findings that are very suggestive of COVID-19, but we both know that the diagnosis of COVID-19 is made in the context of a positive PCR test for SARS-CoV-2. One of the questions that I get from providers who aren't as familiar with point-of-care lung ultrasound is, why is it important to do point-of-care lung ultrasound in patients where you suspect COVID-19? And does it add anything to the diagnostic process? And I wanted to hear a bit about the research that you recently published in Annals of Emergency Medicine, and to get your thoughts on how lung ultrasound fits into the overall assessment of a patient with suspected COVID-19.
Okay, so I think that basically the idea is that we already know from SARS experience, from MERS experience, that lung ultrasound could be useful for the diagnosis in such a viral diseases. So it wasn't so original to hypothesize that it's possible to use it also for COVID. And some Chinese colleagues already describe in February the possible findings using lung ultrasound for patients infected by SARS-CoV-2. I think that basically we decided to have such a study, the study that we published on Annals of Emergency Medicine, because we would like to change our perspective, because we were working in a sort of using a sort of experience-based medicine, but now it's my personal opinion, but I think we have a better solution than evidence-based medicine right now in 2020. So we need to move from experience to evidence-based medicine. So basically, we decided to try to count how many times it's possible to change our approach based on the result of the lung ultrasound. This means that, of course, we know that more or less 100% of time the RT-PCR is positive. We are pretty sure that this patient is infected by COVID, but we can't have the same result among the negative patient, at least at the first examination. So we know that for part of them, we probably could have an advantage in terms of timing, because of course, we evaluate the patient, we perform the lung ultrasound, then probably our probability for that patient increase, and we probably know that we need to put in a specific area far from the other patient, that one with a positive lung ultrasound.
So patients with a positive RT-PCR, you know they're infected with SARS-CoV-2. You don't know whether they're having lung symptoms as a result of SARS-CoV-2. They could be infected and have heart failure or another non-COVID pneumonia, but the lung ultrasound can help to sort that out for you. And then I read your paper, I promise, but I don't have the number right off the bat. What number, there was a non-insignificant number of patients where the initial PCR test was negative, but the lung findings were very suggestive of COVID-19 lung involvement. And then subsequently, those patients tested positive for SARS-CoV-2. What percentage of patients did you find that?
It was about 20%. It was 19.6%, because we had 107 COVID patients, and for 21, the first RT-PCR was negative, but the integrated clinical and lung ultrasound assessment was with a high suspicion of COVID. So we don't stop the diagnostic process. We decide to perform something else. My personal idea is that maybe the COVID could help us in changing a little bit our point of view. It doesn't mean that we can replace the standard physical examination using only the ultrasound. It means that instead of using our ears just on the back of the patient for understanding something about his or her lung disease, now we are using stethoscope, and maybe in the next year, all of us needed to use the stethoscope and adding some more information using an ultrasound machine, a portable ultrasound machine, or whatever all the people have in their own emergency department. So,
Dr. Pivetta, it's always a pleasure talking to you and seeing you. I hope you stay healthy and safe, and thank you for giving us your time and sharing your experience.
Thank you to all of you for your time. Thank you very much.
God, it's always great to spend time with him, isn't it, Mike? I mean, he's just so great.
He's amazing. If anything, you know, his Achilles heel is he'll publish a several thousand patient study and you know, offer his humble opinion. Emmanuel is so humble, but really, for anybody on the webinar who hasn't read that paper, it's phenomenally well done and some really great insights that he summarized there.
All right, well, now we're going to take a quick jaunt across Europe to England, to a group that's leveraged the good work of the Italians, and they'll credit them for it, that put lung ultrasound in place in a very unique model on how they attacked the COVID crisis in their country. Guru Sundar, who's our head of brand marketing at Butterfly, had a chance to sit down with Dr. Joe Noonan at the Royal Berkshire Hospital in Reading, England. And he shared his experience on a truly collaborative model to manage COVID. He really engaged a number of different discipline physicians. It's an incredible program, and one that you want to take note of, and certainly think about how you might employ it in your own institution. Let's run that tape.
Good evening, everyone. My name is Guru Sundar. I'm the Senior Director of Brand Marketing here at Butterfly. It's my pleasure today to be talking with Dr. Joseph Noonan, who works at the Royal Berkshire Hospital in Reading, which is in the south of England. Dr. Noonan is actually an ultrasound fellow in the acute medical unit. Dr. Noonan and his team have actually built a very unique model of deploying lung ultrasound during COVID-19. And we're excited to have him here today to really talk about what inspired him, how did he get approval, what were some of the outcomes that were achieved, and any lessons learned that Dr. Noonan and team can share with everyone so that they can follow in their footsteps. So Dr. Noonan, again, pleasure to have you here with us this evening. May I start by asking you, what inspired you to start this unique triage model?
Thanks, Guru. Thanks so much for having me. I should start by saying that I'm one of the ultrasound fellows in the acute medical unit at the Royal Berkshire Hospital, and that's in the south of England. Reading is it's a very large town. It's got some urban and some rural components to it. And I work for Andy Walden, who for the last 10 years as a consultant in acute medicine and intensive care medicine has worked very hard to deploy point of care ultrasound and to create a culture of point of care ultrasound at the Royal Berks. In March of this year, we received through a WhatsApp group a real treasure trove of material from an emergency medicine physician called Cristiano Pirani in Brescia in northern Italy. And at that time, Brescia was the second hotspot of COVID in Europe. Amongst all this was a triage pathway, which we modified and put through our acute medicine and emergency medicine clinical governance, and then rolled it out across the hospital and then across the locality. And key to this triage pathway was the use of lung ultrasound instead of chest x-ray. And this allowed for GPs locally, which I think you maybe call family physicians, is that right, over there? So these could then use lung ultrasound instead of chest x-ray where they didn't have access to chest x-ray locally, to triage patients with COVID and make a decision about whether they needed to come into hospital or not, based on whether they had normal or abnormal lung ultrasound, and then based on their oxygen saturations.
Can you talk a little bit about what was the outcome that you achieved with this trial?
Sure. So from the first peak of COVID, which was from about April to June over here, we managed 300 patients in the virtual ward at the Royal Berks. And to put that into perspective, I think there were about 900 patients with COVID admitted at the Royal Berks. And this virtual ward, so what this was patients in their homes, out there in the community, in their front rooms, their bedrooms, with their SATS probe, monitoring their SATS 4 times a day, doing the walking test, which involved walking 30 meters, and then sending their numbers in to us. So we managed 300 patients during that period of time. But just to go back a step, if you think the GP Hot Hub was sending us patients with lung ultrasound changes on their when they scanned them, there were many patients they were scanning who didn't have abnormal lung ultrasounds that they were able to send safely home. So of those 300 patients, we had 1 death. We had about a 10% readmission rate. So to put that into perspective, we aim for about a 10% readmission rate in our ambulatory pathways over here. So we hit that number, 10 to 20%. So it went very well. And then we started everything up again when the second peak hit. So there have been 119 patients in our virtual ward this time round during the second peak. 13 patients have been readmitted to hospital, and 5 have reattended the emergency department or the Hot Hub and then been sent home. So we're still going, and as of today, the numbers of patients in the virtual ward has shot up to 24. We're taking renal patients. This is something we're quite passionate about. The hemodialysis patients, they have to go into hospital 3 times a week. It's pretty miserable for them. And then during COVID, they were particularly vulnerable. So this time around, we're taking all the hemodialysis patients who are COVID positive. We're also taking pregnant patients who are COVID positive, as per the Royal College of Obs and Gynae. So we're really working with other departments in the hospital to collaborate with them so that we look after the lung components of their COVID illness, but then the renal department look after their renal side, or if they're maternity patients, they're looked after by the obstetrician. So there's a real collaboration between different departments here.
Dr. Noonan, COVID hit us hard earlier this year, and I think specifically in the UK there was a second wave that just happened. You all went into another phase of quarantine. What changed between the first deployment and the second deployment when that wave hit again?
Yeah, we had that first wave between sort of February and June, and then we had a nice quiet period in many ways where we could kind of get back on our feet. And then the second wave hit, and we've just come out of lockdown from that. What we did essentially was roll out the same model of triage pathway called TIC-19, triage into the community for COVID-19 patients, but we upscaled it. We started taking in much higher acuity patients, such as patients with renal failure on hemodialysis and pregnant patients. So all pregnant patients with COVID are being monitored by us in our locality. This required a collaboration with maternity for the pregnant patients. So we're looking after their sort of COVID lung side of things, but then maternity are looking after the pregnancy issues. And with the renal patients, it requires collaboration with the renal department so that they're looking after all the renal side of things. But again, we're just looking after the lung side of things. The other thing is we've trained up more people in lung ultrasound. And there's clearly a lot more interest now in point of care ultrasound after the first wave, having seen the way that lung ultrasound can be used. The local hot hub, it's fantastic that it's not only in GPs, but we've just trained up an advanced nurse practitioner who's clearly got a fantastic knack for lung ultrasound and is very good at it. So I think this is a fantastic positive step.
Well, Dr. Noonan, it's been an absolute pleasure to have you here with us. It's been great to talk to you live about your insights, your learnings, your passion, and I look forward to working with you more and more and seeing the model scale even more. So thank you again for your time.
Thanks so much, Guru.
It's a pretty cool application. Yeah, really, it's the regional variation in the ways in which people are implementing POCUS for suspected or confirmed POCUS COVID is really still kind of mind blowing almost a year later.
It's really interesting too, the way these guys engage their GPs, set up a new model. I think they really accelerated learning in their community and how it actually ultimately went on to be viral with other people learning how to do it. And I think that's part of the message of this evening that we want to learn, and that how do we actually leverage what we've gotten from lung ultrasound? And the question of the day, should it be the standard of care? And we'll have a little bit more of a discussion on that later. But now we're going to travel across the pond to Philadelphia, where we're joined by Dr. Ryan Gibbons. And he's the director of ultrasound at Temple. And he recently had the audacity to challenge the sanctity of chest x-ray. He published a great paper comparing lung ultrasound and chest x-ray. Welcome, Ryan, you upstart.
Thanks, John.
So, can you tell us about the paper that you wrote? What were the key findings and what motivated you to take on that portable machine running around the hospital?
Yeah, definitely. So I think the motivation came from evidence that we saw in other viral pneumonias like H1N1. The sensitivity there far exceeded chest x-ray. And the volumes we were seeing initially were kind of overwhelming our department. And we needed to find a safe, efficient, and accurate method to screen through some of these patients. Certainly, they weren't all eligible to get an X-ray or a CAT scan. Swabs were limited. And then even symptomology is very non-specific. So, what may look like COVID may be something else. So we figured lung ultrasound using the portable machine would be a good way to limit exposure to a lot of our providers. It would be a good screening tool, especially in our tents that we had set up outside the ED to help identify some low risk patients, get them out without having them actually come into the emergency room. And then conversely, identifying some higher risk patients that would need to come in for further imaging. And working with our crit care department, we really wanted to focus on patients that had radiographic evidence of atypical pneumonia. In this case, we assumed COVID-19 pneumonia given the ongoing pandemic. So what we did over a 2-week period in April, we enrolled 143 consecutive patients with what we considered were signs and symptoms of COVID-19 based off of, what our hospital was looking at as far as hypoxia, fever, loss of taste, smell, things like that. Each of the patients would receive a lung ultrasound done by one of the emergency medicine faculty or resident, looking in 8 different zones. We would then have them have a portable chest x-ray done. And ultimately, if either of those were positive, they went on for a non-con CT scan to further delineate, is there actual radiographic findings of COVID-19? And if there were, where are we going to put them in the hospital? Because we had certain areas that were specific for COVID-19 only. As far as lung ultrasound, what we defined were the presence of B lines, irregular pleural line, pleural effusion, or subpleural consolidation. And they had to be present in 2 or more lung fields for us to consider that positive. Chest x-ray, we define any mention of opacity, infiltrate, interstitial process, and we even included atelectasis to help further our sensitivity with x-ray. Ultimately, what we found was our study population was 110 patients that received the lung ultrasound, the chest x-ray, and the non-con CT. And of those 110 patients, 83 had a positive non-con CT chest, which was defined as ground glass opacities, which was consistent with COVID-19 pneumonia. For lung ultrasound, our sensitivity was 97%, and this was based off of the performing physicians, very few of whom had completed a fellowship in ultrasound. When we did an expert overread with our ultrasound faculty, lung ultrasound was 100% positive. Comparing that with chest x-ray at best was just about 70% sensitive, and that was including atelectasis as a positive finding. When we did include that, the sensitivity dropped into about the 60 range. So pretty poor sensitivity for what is often considered a standard of care test to diagnosing pneumonia. So ultimately, we were finding lung ultrasound, similar to past studies, was incredibly sensitive for diagnosing COVID-19 pneumonia. And it really helped us identify a number of patients that would have otherwise been missed just based off of symptoms or vital signs. And we really pushed to find those individuals because they were the ones that were more likely to be admitted, more likely to have a prolonged hospital course, more likely to require treatment at the time. So that's what we've been using fairly regularly now, especially as we ramp up again with our numbers that we're seeing in this recurrent surge recently.
So have you killed chest x-ray in your hospital? Is it done? The x-ray tech's been sent home now and they're now filing for unemployment?
If it was up to me, I would. I hope none of them are listening right now, but no, we still haven't gotten there yet. I think, listen to a lot of our panelists tonight, point of care ultrasound, we've made incredible progress, but it's still something, that we're working on to have other specialties buy into. But from an emergency medicine standpoint, at least at our shop, most have bought into it and use it routinely. So we're still working with our other colleagues though outside the emergency department.
And the ubiquitously across your department, is everybody pretty well trained in ultrasound in your shop? And have you heard from other people across the country about your paper and go, wow, should I change what I'm doing?
In our department, we're fairly well trained, and this came down from our chair, who when he took over, I mean, this is over 20 years ago, he really mandated that our faculty from the top down be really well trained in point of care ultrasound in order to train the residents coming up. And we have a fairly robust ultrasound division. Tom Constantino is our division leader, who's very well known in the ultrasound community. He's been very active over the last 20 years. And there's about 7 of us in the division. So we have a really good oversight and training as far as our point of care ultrasound goes. And obviously that's I think we're unique in that situation, at least compared to a lot of community places. I think a fair amount of academic places, are similar. As far as response, I mean, we've gotten really good response as far as people looking to change, their approach and their use of lung ultrasound. I think the biggest hurdle is getting quality training and having a QA system to really keep on top of what's happening and to get, again, quality training.
Well, this is a really important paper, and I think one that's going to get referenced a ton. And I think you're to be commended for this work. And we're going to pull you in a little bit later in this conversation as we get to some Q&A. But I want to thank you for joining us and for contributing here. And we're going to address the issue of education with Mike Stone a little bit later. But thank you very much.
Thanks, John.
Well, we're fortunate tonight to be joined with a physician who's done just that. And I think it's prudent for all of us to extract all of these learnings, including Ryan's paper and Pavetta's and more to come, to follow in their footsteps. So our next panelist is Dr. Dan Duran. He's the chairman of radiology. Yes, we've got a chairman of radiology here talking about point of care ultrasound. He's at LifeBridge Health, which is right around the corner from me. And Dan's a really talented guy. I would encourage all of you to review his list of accomplishments. They're kind of staggering, actually, and I'm humbled to have him join us tonight. So Dan, if you're here, let's jump on, and I'd love for you to describe for everyone tonight what exactly you actually pulled off at LifeBridge.
Yeah, so at LifeBridge, for many years, there have been a few aficionados within the orthopedics department and the emergency department with regard to POCUS, but there wasn't widespread adoption, which was, I thought, a missed opportunity. Maybe a little bit different than most radiologists, but I really believe that the more we democratize the technology and the more data we gather, the better our overall health system functions with regard to diagnosis. And ultimately, the more important, frankly, we are as imaging diagnosticians. So that's my philosophy. And I encourage other folks, both within my discipline and others, to sort of apply that in their discipline. So during the beginning of COVID, we were faced, like a lot of folks, with a couple of problems. One of the problems was just the high rates of PPE consumption. I think we saw that all over the world, really. But within Maryland, we needed a way to continuously, both on the way in and then continuously assess ICU patients from an imaging perspective. And we were all, trying to focus on limiting the amount of folks that went in and out of rooms that would each need to be garbed with PPE. In those days in Maryland, the turnaround time for a COVID PCR was something like 7 to 10 days because LabCorp was really backlogged. So I'm talking now about really mid-March through about May of this year, before there was wider testing availability. Things move quickly, and it's almost easy to forget that. Now it's very easy to get an antigen test or a PCR test. And during that time period, we really needed to be able to get positive findings, particularly the confirmatory findings, and be able to say this person almost certainly has COVID. Let's get them to one of our COVID specific units. And this is where we really needed to have multiple POCUS units, and both the flexibility of Butterfly as well as the price point and the usability let us bring this to a large group of physicians. So we engaged physicians in ER, on the floor with the hospitalist group, and our ICU groups in all three of our hospitals. And we deployed 12 devices, 5 in 2 of our biggest hospitals and 2 in our smaller hospital. So we have 5 hospitals in our system, but only 3 of them are really acute care hospitals. And the hospitals are Sinai Hospital of Baltimore, Northwest Hospital, and Carroll Hospital. We use the online resources that you've all provided, as well as myself and others taught simulation classes using phantoms in our lab. And we got people trained up on how to spot the lung pathology and the effusions in particular. And the findings that other folks have talked about, we were able to reproduce those in the ER and the ICU. And there has been rapid uptake. We have 12 super users using it across 3 hospitals. And we've also found that this experience with the health system being willing to implement and willing to do something different because of COVID has actually resulted in a lot more interest in POCUS. So now we have folks using a lot more POCUS for things like thoracentesis and paracentesis to get those done on their own without referring them as much to interventional radiology, which we appreciate. The settings have been mainly on the floor, intermediate care, CCU, and ER. And the systems, in addition to the lungs, we've had folks use them quite a bit for vascular, cardiac, cardiovascular, renal, abdominal, and GU exams. And the biggest users do seem to be in the ER and the critical care areas where the patients spend a bit more time. There's a bit more problem solving going on. And lastly, we've noticed that we're getting called, or we're getting asked to do less of the sort of reflexive type ultrasound. So someone has a acute kidney injury, they're not necessarily always asking us to rule that out with a renal ultrasound. They're able to demonstrate that they don't have obstruction, or they do on their own. And so we're seeing less unnecessary or sort of borderline overutilization. So we're happy with it on the radiology side because we're trying to conserve resources as well at this time.
So Dan, a big change, and I know your CEO well. He's a really smart and innovative guy. How much of a difference do you think it made, you being kind of the chair of radiology driving this, and your connections with the senior administration? I mean, those are typical obstacles to get people to change. How important was it that you were a radiologist to make this happen in your institution?
Yeah, I think that helped quite a bit. I mean, being a radiologist isn't going to make other people want to use it. So I think the usability and the sort of COVID as a catalyst, so one of these big inciting events, and makes people think about how they need to practice, and you solve a problem for them, which here it was the problem around access, right? Because it was difficult to get access to testing, and also because of the turnaround times associated with room cleaning, difficult to get access to other types of imaging. So I think what really drove the adoption, was I did my best to drive it, and I think they probably appreciated some of the advice we were able to give and the facilities we made available. But I think what drove the adoption by the providers is the fact that this solved a problem for them. But you're right, in terms of getting funded, I think the biggest thing that a radiologist can do in these situations is not be defensive and not stand in the way. And we have several different hospitals. So in some of the hospitals, that did take a little more cajoling and reassurance, where I was talking to some of the other radiologists, because there is this sense of turf protection around some of these things. But it's like I say with most of change management and innovation in medicine, you really need to engage the provider on and remind them what brought them to medicine. And people aren't doing radiology to be obstructionists, right? People are in this because they like the analysis. They like the idea that in medicine, by doing well, you can also do good. And you need to sort of figure out what the hangups are. If it's just about turf, it's, remind them of what we all do this for. Sometimes it's a bit more than that. Folks are concerned that people will not understand the information, or that people will think they see something and then require more imaging. And it's pretty easy to talk folks down from that by just letting them actually implement an experience. So we haven't seen any of that. We have not seen a bunch of unnecessary imaging. We haven't seen people doing therapeutic misadventures because they're not trained. They're not radiologists with 6 years of training using ultrasound. We haven't seen that. We've seen people, frankly, feeling more autonomous as they manage their patients and able to practice higher up in their licenses.
I was interested on your end on how long you felt like the training took to take people from sort of zero experience to at least minimal competence.
We used a super user model, and it was honestly mainly there's a hospitalist and an ER doctor and an anesthesiologist that had I'm not sure if they had fellowship training or if they had just come to use this. I imagine they have taken some courses, but they were the folks that had been. There were 3 folks in our health system that had purchased their own devices earlier, right? And they were kind of using them, but it wasn't sanctioned by the health system. And so a lot of the work of the that happened right before COVID was things around information security and HIPAA and all that to get my clinical engineering folks comfortable with this as a solution. And it was very timely. So yeah, I kind of left that part out, but we had a few folks that were well trained and they were on the floor. And they've done the majority of pushing this out. My role has been mainly to sort of educate the masses as to how this is useful and that it can be trusted. I've given some grand rounds on what the imaging findings look like, and directed folks to the educational materials that, frankly, you all have made available. And we have a simulation lab that the hospitalists have used to teach ultrasound. But so I think I'm trying to, I don't have a quantitative measure of it. We didn't study it the way some other folks have. We didn't study this in an academic context. It all happened much faster than that.
Sure.
So I would say that it was within weeks to months. There was a core group of users, and the amount that are using this a lot went from 3 individuals pre-COVID to 12 post-COVID, and essentially that's I attribute to that we bought 12 devices, and so what we've seen is that in each area there will be at least one individual that really learns from someone in a different area or online resources, etc., and really becomes the sort of local guru for this. And that's sort of what we've seen.
Well, thanks, Dan. This is a great segue, Mike, into talking with Nareen about some images, the findings, and obviously, Dan, you can, as the radiologist in the room, you can add some color to this if you wish. And Mike, why don't you take it from here? Let's talk about some education.
Sure. I'm really excited to have Dr. Nareen Ahmed with us. We're going to go through and take a look at some representative images around lung findings in patients with COVID-19. As a quick overview, lung ultrasound really relies on the identification of ultrasound artifacts. It's a different type of ultrasound than, say, looking at the gallbladder or the aorta. And these artifacts all arise at the interface between soft tissue and the chest wall itself and the pleural surface. And there's a lot of subtleties to lung POCUS. You can get really, really deep into identification of peripheral pulmonary emboli, into lung masses, into all kinds of findings. But the core really involves the identification of lung sliding, A-line artifacts, and B-line artifacts. And that'll really encompass most of the disease processes that affect the lung, including COVID-19. So just as a quick review, lung sliding, that's sort of to and fro, left and right movement at the pleural line that indicates that the visceral and parietal pleura are opposed and sliding against each other. In the center, A-lines or horizontal reverberation artifacts that indicate essentially air underneath the pleural surface. So an air-filled lung in this case, you'll see A-lines in the case of a pneumothorax, although you won't see sliding in that case. And then B-lines, which can indicate a number of things, these vertical hyperechoic lines that start at the pleura, go all the way off the screen without fading, erase the underlying A-lines and move with respiration. These really are most commonly seen in anything that'll make an opacity on a chest x-ray. So whether it's pulmonary edema, pulmonary contusion, pneumonitis, pneumonia, ARDS, those pulmonary fibrosis, all of those will give you that sort of B-line pattern. We can't really talk about lung ultrasound without talking about zones. And, although an 8 zone, 4 on each side, as referenced in this image on the left here from Dr. Volpicelli, is a very common approach for patients with acute dyspnea. I do think it's really important to include the posterior zones in patients with suspected COVID-19, because we know that COVID can affect the posterior and inferior lobes. And on the right here, you see just a snapshot of the lung protocol that's now up on. If you're in a lung preset and you're scanning with IQ, you can go into the Actions tab and pull this up. And as you tap on the different portions of the lung, it'll automatically label that segment for you, which is, as somebody who used to QA and review lots of lung ultrasounds in an academic setting, it's really nice to have those labeled so you know what portion of the lung you're looking at. So just something I'd encourage people to play around with. So that's enough of me talking. Nareen, you want to walk us through some of the things we're seeing on the next few slides?
Yeah, absolutely. Thanks for having me. So before I even talk about what we're seeing on the lung ultrasounds that you see in front of you, I think it's really important for a lot of us to remember the common findings we see on chest CT with COVID, because I think it really helps put into context what we're seeing on lung ultrasound. So just to kind of remind everybody, some of the things that we see on a CT of a chest of a COVID patient, we are typically seeing ground glass opacities with or without consolidation. Usually, as Mike had mentioned, predilection for lower lobes, peripherally located. Typically, you're seeing bilateral lung involvement, multifocal with areas of sparing. So I want you to keep that in mind. And often we do not see pleural effusions, and if we do, they're quite small. So kind of thinking through that, it's important to keep in mind when you're scanning what what you think you're going to see if you have a COVID-19 patient. So what you're seeing here in the screen is a comparison of normal lung, which you're seeing on the left, and a comparison to a patient with COVID. And what you're seeing, so if you just focus on the image on the left side of your screen, I want you to notice that the pleural line, which is that first hyperechoic or bright white line at the top of the screen that Mike's pointing to right now, that is a crisp, thin line that looks very regular, and you see it reflected down the screen, which is the A lines that Mike referred to. In the image to the right, what you're seeing is focus again on that pleural line. It looks a bit irregular, it looks thick. And then what you're noticing is B lines on the screen as well. And those are those vertical lines that go from the pleural line to the bottom of the screen. Often you might see discrete B lines, or more frequently you're seeing confluent B lines, which is kind of what you're seeing here.
All right. So just another couple of examples to kind of illustrate the spectrum of disease you can see in COVID-19.
So what you're seeing here, and again, I think it's really important to remember that these images can be coming from the anterior lung, can be coming from the posterior fields, or that lateral, that axillary field that you're looking at. If you think through the image from Volpicelli that Mike had on the screen. And again, really important, you might see areas that have A lines, and you might see areas like this where you're seeing, again, a thickened irregular pleural line. You're seeing those B lines, sometimes confluently, which just means several B lines together. Or here you're seeing, in the image to your right, you're seeing some subpleural consolidations. So the important thing to keep in mind here is that usually with COVID-19, we don't see those larger consolidations that are greater than a centimeter from the pleural line. We're typically seeing smaller, those subpleural consolidations that are usually less than a centimeter from the pleural line. Of course, not all patients read the book, so and COVID is very new, so we're of course discovering so many different things that we're seeing, but this is the usual pattern that we notice. And again, those subpleural consolidations, what you'll usually see and what you're seeing here on the screen, you're seeing an area that's not aerated, surrounded by an area of aerated lung. And we can go to the next slide to kind of see what that comparison looks like to pneumococcus, which you'll see a much deeper, larger consolidation, which you're seeing on the image to the right versus the image to the left, which is in a patient with COVID. Again, that thickened pleural line, confluent B lines. But again, that image to the right, if you're seeing this on a patient that you know has COVID, you should be worried about a bacterial superinfection. That should be something that you should be thinking about. I think that's incredibly important to recognize that these images that we're collecting, often they come serially in a patient's hospitalization. You might see some version of B lines in the beginning of a patient's hospitalization. They may get worse as the patient gets worse as well. And then throughout that hospitalization, maybe you do start to see consolidations, and that might clue you into potentially a bacterial superinfection. That's kind of to give you a little bit of an idea of how we utilize lung ultrasound serially through the patient's hospitalization. And here, I
think it's a great point. Oh, yeah, sorry, go ahead. Sorry, go ahead, Noreen.
No, I was just going to say this is often what we refer to as a shred sign, that image that you're seeing on the right. So just wanted to point that out for anybody that's new to ultrasound and kind of learning the terminology.
Yeah, absolutely. And you may see some air bronchograms inside of that consolidation as well. I think it's a great point that, if we take as truth that lots of people with COVID-19 are asymptomatic, there almost by definition have to be patients out there with COPD exacerbations who test positive for COVID, and patients out there with heart failure exacerbations, especially with less contact with the healthcare system due to concerns about exposure, who may be COVID, SARS-CoV-2 positive, but experiencing an exacerbation of their heart failure. And most folks, when they learn about lung ultrasound, learn B lines equals pulmonary edema. And I just thought it'd be great to look at some of the subtleties between a patient in this case with pulmonary edema and here another patient with COVID-19.
Yeah, so this is a really, I think, as an ICU doctor, I often am challenged by the question of volume and pulmonary edema in the context of somebody who maybe came in with pneumonia, was resuscitated, and then, we're trying to figure out what's the difference between this B-line? Is this something that's part of an infiltrate that's related to pneumonia, or is this pulmonary edema? Well, that's much more challenging a question in a patient like that. However, with COVID-19, there are some subtle differences that I think are important that help us differentiate. So the first thing is, as I had mentioned earlier, oftentimes with COVID, with those ground glass opacities, you're seeing areas that are spared. You're seeing skip lesions is what we kind of refer to them as, where you might see an area of confluent B lines adjacent to an area of A lines, which is kind of what you're seeing on the image to your left. You're also going to see that thickened pleural line. An irregular pleural line is often what it's referred to in patients with COVID. And as you scan the patient's chest with COVID, again, you might see areas with B lines and areas that are spared. Whereas in pulmonary edema, you often might see more discrete B lines. Typically, the pleural line should be pretty crisp. And then and typically, if you think about pulmonary edema, it's a bilateral process that usually involves both lung fields, whereas COVID-19 is usually a little bit more multifocal with skipping certain areas of the lung. So that's the typical thing. And then, of course, with pulmonary edema, this is, I think Dr. Duran had mentioned this as well. We can't really, and Ryan had mentioned this, and everyone kind of has, was that lung ultrasound is a part of the bigger picture. It's a part of the clinical exam. It's a part of the story. It's a part of the physical exam as well. And it's an adjunct to all the information that we have. So I think in looking at these images, if you're still wondering, well, I'm not sure, if the patient was in front of you, you might have more answers to help you determine, but those are some of the subtleties that you would see on ultrasound.
Fantastic. And then lastly, this is an area I think that's really unexplored, is sort of what's the normal time course to return of a normal lung pattern in a patient with COVID-19. And this was submitted by one of our users in Italy, so thank you. This was the same patient about a week apart. This was about 3 days after a PCR test positive for SARS-CoV-2, and you can see many of the features that you were already speaking about. So, thickened or irregular pleural lines, skip lesions, some A lines, some confluent B lines, and then a really nice slow survey of the lung about a week to 10 days later, showing this really clear A line pattern. And I was just curious, not going to make you comment on these images that we just looked at, but are you seeing resolution in your ICU patients? So sort of as their clinical condition improves, are you noticing patterns in terms of resolution of B lines, or are they still showing signs even when they're clinically better?
Yeah, I mean, this is I'll be honest, from a realistic standpoint in the ICU, by the time the patients are leaving the unit, they're still on some degree of high flow and oxygen. So we expect that there's still going to be some findings of COVID on their lung ultrasound, which there are. I would say that would be a curious question, a question for hospitalists that are seeing patients a little bit closer to going home. I will say that this brings up a really interesting point, that yes, the findings that we're seeing definitely lessen as the patient gets better. But the other thing that I find really important, and the implication here, is some of those patients who go home still with findings on their lung ultrasound and what that means for them down the road. As a pulmonologist, we're seeing some really interesting, long-term effects of patients who still continue to have lung injury, or who come in a few months later with, with ground glass and some consolidation that's not just your typical pneumonia. It almost looks like something like an organizing pneumonia, and how that's related and what's happening in that post-COVID phase. And I really think following our patients with lung ultrasound to see if they fully recover back to normal appearing lung, or if there is residual lung injury left, and what we do with that, I think there's a lot of discussion about that now, and how to really think about that and put that into perspective.
Yet more areas of research that need to be done with COVID-19. Fantastic. Thank you so much. Really, really appreciate your expertise and your insight here.
Thanks. This was great.
So we're drawing near the end, but I want to take the opportunity to kind of pulling all of you together and kind of pose the question. So obviously this is a little bit like being in church and giving a sermon and talking about the importance of going to church. I guess all of you obviously have adopted point of care ultrasound, but I know certainly from the experience that I've seen now that is still not kind of the ubiquitous, if you will, standard of care. Where do you guys think we are in that journey, and what do you think it's going to take to get us there? Let's kind of throw that open as the question of the day. Should lung ultrasound be the standard of care now, regardless of COVID? I mean, I think COVID, it has just such huge opportunities, but regardless of COVID, should it be that? And I guess the other second part of that question is, we likely have a good 5 to 6 months of COVID left. I mean, I think it realistically, and certainly 2 more months of serious activity. Is it too late for people to get in the game right now, adopt what these great examples of expertise are, for people to put this into play and to make a difference in the way they're delivering care in their institution? So I'll throw those 2 questions out and look forward to your response.
I mean, from an emergency medicine standpoint, I don't think it's too late, because I think using it in the context of at least COVID-19, you can implement it from a screening protocol. If other places have volumes similar to what we're seeing at Temple, we need something that's quick, efficient, and accurate to screen patients, to find the low risk and high risk ones. And honestly, I think some just focused training. I don't think you need months and months of training to pick up on some of these findings that were described, especially B-lines. That was the most common thing we were seeing in our study. And I think it's prime to jump in with the bedside lung ultrasound from an emergency medicine standpoint, to relieve some of the volume that we're seeing, and to screen away some low risk patients and identify high risk ones that we otherwise might miss.
I do want to answer the question that you first posed, which was, can we make lung ultrasound standard of care? This is, as a lung doctor, this is a really challenging question for me, because I find that there are so many nuances on a CT of a chest that help with a differential diagnosis. Outside the conversation of COVID, I think it's really challenging where things stand right now to say that we can fully eliminate all other chest imaging. I realize that's a controversial response in the setting that we're talking about, but I think that all it means is that we still have a lot more to learn. And if we're going to answer that question definitively, I'll give you the best example. Patients who are that we're treating with COVID, who are in the ICU for a prolonged period of time, especially patients who are immunosuppressed, we have seen fungal pneumonia, aspergillus. How can I tell the difference on a lung ultrasound outside of just clinical suspicion? That what I'm seeing is not necessarily new bacterial pneumonia, but something like a fungal pneumonia, if I don't have any microdata yet to support that. So I'm just sort of throwing out some examples of when a CT and looking at some CT findings would be somewhat helpful in differentiating. But I just think that means we have a lot of unanswered questions with lung ultrasound and the different diagnoses that we're seeing. And the more we learn, the more we might be able to answer that question a little bit more thoroughly.
I think it's important what you brought up, and I'm certainly not, I don't want to take away Dan's CT scan. I guess the question is less about taking away the CT scan and more about throwing away your stethoscope, because, when someone comes in and listening with a stethoscope, I know ultrasound's better than that. So I certainly can see situations and using clinical judgment where, the ultrasound replaces the stethoscope and maybe limits the number of CT scans, but I don't want to get rid of the CT scan either. I think your point is very well taken.
Yeah, and I think similarly, that's always a question we're asking ourselves too, right? Can we eliminate the stethoscope, or can I just go in and look at a patient with the ultrasound? And I think I'm constantly reminded about patients who are wheezing and what that means to me as far as management and how we're unable to see that on an ultrasound. And so I think. Again, it's a scenario where I think we're close, but that there are a few things that we can't fully eliminate the stethoscope quite yet. But I do hear you, where I think we're seeing a lot more with the ultrasound that just allows us to really make diagnostic decisions.
Yeah, the way we use it, especially at the bedside in the emergency department, because we have a lot of undifferentiated dyspnea coming in. And using an ultrasound first approach, at the very least, can guide your diagnosis and treatment, and at least eliminate some of the possible differential diagnoses in conjunction with all the other things that we use for a diagnosis. But I definitely see the benefit in it narrowing. People come in with heart failure, COPD, other reactive airway disease. It's tough at the bedside to really delineate what's going on as they just roll in. And, I find the benefit greatly in an ultrasound first approach. And that's kind of what I advocate, in addition to, our other standard testing.
I fully agree. I think as a critical care consultant, we attend a lot of the rapid responses on the floor, and often they are in relation to respiratory distress, especially now. And so it is by far one of the most helpful tools to have with me at the bedside to determine what to do in that immediate, 5 to 10 minutes. What is something I can do to reverse this process? And the ultrasound findings are very useful in scenarios like that.
Mm-hmm. Yeah, it's really interesting. I'd be less likely to compare ultrasound as or to posit ultrasound as a possible replacement for chest CT. I agree with all the comments that have been made. On the other hand, comparing it to, and I'm not going to get into the wheeze detector, otherwise known as the stethoscope, but the comparing
Mike,
it
a
to portable
surgeon's
chest
response to
X-ray.
wheezing is, the surgeon's response to wheezing is, if you need a stethoscope to hear it, it's not that significant. So what are you doing?
Yeah, I'm not going to ask you the last time you used a stethoscope, John. But
I'm hurting as a
the likelihood, but I do want to highlight Dr. Weimersheimer, who posted into the chat, likelihood of portable chest X-ray being more illustrative than lung ultrasound is wicked small. POCUS first, then non-contrast CT as needed for more definition as a question mark. I think that, this is one of the really interesting things that I got into with Dr. Pavetta, but was too long to include on the segment here, is it's really challenging to do diagnostic accuracy studies when the gold standard you're comparing to may not be as good as the test that you're using. And would be really interested in Dan's take on chest X-ray for this. We know findings lag, we know lung ultrasound, there's a pretty large body of evidence that it really does way better than chest radiography, not as good as chest CT. But sort of where do you feel like there's going to be a role for portable chest radiography in a world where people are more comfortable using and interpreting lung ultrasound?
Yeah, I mean, personally, I think that if we had our super users, right, at the front line 24 hours a day, 365, we would, and I'm in what I would call an academic community health system. So sort of one of our centers is quasi-academic and has a fair number of residency programs, and the other two hospitals are much more community-like. So I think what I experience is pretty representative of a lot of the hospitals in the US. If the right people were on 24 hours a day, I think we could have that pathway, because chest X-rays are pretty, inadequate for detecting COVID. I mean, it's a first-line screening test. If there's anything that looks at all like atelectasis these days, you end up sort of overcalling it. But if they have the right clinical symptoms, they're going to get a PCR anyway. They're likely going to get a chest CT anyway. And earlier in the pandemic, when we didn't have good turnaround time, we were just going past chest X-ray, going right to chest CT in many instances. A lot of that had to do with our need to sort of triage people and figure out where they would go in the hospital when we had these sort of COVID and non-COVID units, which is no longer our approach to it, as we've evolved to something else. So to answer your question, yeah, chest CT clearly is going to be the gold standard, and it's less operator dependent, and it has the higher resolution in the central areas. I think chest X-ray is likely inferior for this disease. I think it's inferior for a lot of other things. I mean, for years, we've known that the physical exam is actually better than chest X-ray for congestive heart failure. Chest X-ray is not good at all for congestive heart failure. I mean, I think people kind of know this. And but ultrasound, there's many things you can do. It really depends on how many systems you're good at evaluating. But you can see a lot of things real time between cardiac and lung and infusions and other organ systems that, along with your physical exam, that could likely yield a much higher ROC than chest X-ray ever can for congestive heart failure, right? So I think a core of ER doctors with good training, and really, it's not just training. To me, it's really experience, and it's that constant learning and the feedback that you all get that would make you, like Dr. Stone and others, the folks that use these things day in and day out over years, will get better and better at them. So I think up front, that's probably the best way to evaluate the lungs. There probably are still going to be a need for chest X-ray. I think in the ICU also, the daily chest X-ray, we've gone away from that for many years, but being able to follow someone longitudinally for whatever's going on with, whatever their condition is, instead of just doing a chest X-ray every day. And really probably we'll end up using chest X-ray quite a bit less in the ICUs. It might be more about just evaluating certain types of lines and other things that might be difficult to appreciate on ultrasound. So I expect that there will be less chest radiography in the ICU setting as the uptake goes up. And frankly, from our perspective, from the radiologist perspective, that wouldn't be a bad thing either.
Yeah, I will definitely second that. We are using X-ray less and less in the ICU. I mean, it's really tube placement and line placement. I mean, those are the things that are that really remain for the daily X-ray. Outside of that, just the other day, we had a patient who I was asked to evaluate a pleural effusion, which the X-ray just did not catch as nicely as the ultrasound. This is a patient that's in an ICU bed who we really had to sit up and look posteriorly to find that large pocket. And so I think it's really important to recognize that.
Yeah, you can hide a very big effusion on a chest X-ray. One of the things is for very trace effusions. I like ultrasound actually, and this comes up in peds a lot where we're doing dose reduction, so the pictures aren't quite as crisp as you get with adults. But with very subtle effusions, a lot of the times you'll be saying, look, that could be sort of atelectasis in a dependent pattern, or it could be trace fluid, and you have to use an ultrasound to figure it out. Right. So there are some things where ultrasound does beat chest CT, and sort of subtle effusions layering posteriorly is definitely one of them.
Well, this has been great, and I want to thank you all very much for participating in this. We've gone long over, but I think it's been content that's well worth it, and I think that with the recording, we'll share it with others. And they stand to learn a lot from your examples. And we appreciate you guys being apostles for the future of healthcare, which I believe this is. It's interesting. This pandemic is going to define this time of history. I think there's no doubt. And there'll be scores of books written and stories told and legends created. This will define our time in medicine as well. And we'll recall what role that we've played long after all of us have retired. The bravery that all of you have shown, because you practice, and the dedication and personal sacrifice that you make and so many have made have been on full display for the world to see. And I think we can be very proud how medicine has responded during this time. Things in healthcare have changed as a result of this pandemic. I can think of many of them, like our tolerance of hypoxemia without intubation. That's new. The role of telemedicine is certainly evolving, and we shoved it forward. And I think what's demonstrated here in this webinar is the emergence of point-of-care lung ultrasound, that having a key role in the assessment of lung pathology. We can debate when it will take over as the principal role, but clearly now the momentum is for everyone to learn this and to incorporate it into part of the way in which they practice medicine. I'm grateful for you guys as leaders. I'm hopeful that your example will lead the kind of rapid adoption by all healthcare providers to actually pick up a stethoscope and think about using lung ultrasound as the first choice. I think the evidence that you guys are producing demonstrates that. And candidly, in my opinion, I think it's just better medicine. And I thank all of you for actually practicing that. So thank you again. And we'll look forward to catching up with you again as you guys continue to obviously lead the way for the rest of us in this country. Thank you.